our guest and our senior is Dr. Abubakr Elmardi. Dr. Abubakr is a dictionary. For us to give his biography, it will take long. So we have some summary that I have to tell you about him. Okay, Professor Abubakr Elmardi is currently a head of Obstetrics and Gynecology Department and consultant obstetrician and urogynecologist. He's also a head of urogynecology units and pelvic floor reconstructive surgery and a head of cosmetic gynecology unit in Royal Hayale Hospital in Kuwait. He's currently working in Kuwait. He's also an associate professor of obstetrics and gynecology at St. George, Grenada, and a senior lecturer at Keele University Medical School, UK. He's also a former deputy chairman and for postgraduate school in Birmingham West Midland University in UK. Professor Abubakr is a Sudanese and is currently working in Kuwait. So he's the one to give us this very important topic about the language of care, the language that we need to use when we are taking care of patients. Prof, you are welcome. We will have presentation from him, and then later on there will be chance for questions and comments. Okay, welcome, Prof.
Yeah, thank you very much for the invite. I think we met in Cairo in one of the conference down there, and I do joined Kuwait recently in the last 7 years. I was in the United Kingdom for nearly 25 years, and I was planning to one day to come home, but unfortunately, we all know what's happening at home. It's a privilege, and I want to take this opportunity to congratulate South Sudan for their fantastic team of the basketball, which is a beacon for Mother Africa, and we are going to support that team till the end. So now I will start my talk. I think we know that medicine is a lot of improvement in medicine. We're now having minimal access, we're having laparoscopy, we're having, and now artificial intelligence is coming. But the point that is not enough for patient. I think patient demand or request that we know how to talk to them, how to greet them. So that's the talk which I would like to share with you, language of care. I don't have any conflict of interest. And I'm just going to ask you this question. Which doctor you would like to pick? If you have two clinicians, they both graduated from a good university and they're both well educated, will you choose a physician who is kind and warm, or do you choose the one who is cold but graduated at the top class in medical school? So I'll start my talk with this comparison. I think my favorite quote I would like to share with you is, I think we all know Dalai Lama. Dalai Lama have said this quote by saying, real care of sick not begin with costly procedure, but by simple gift of affection and love. And that's what patients want. Yes, I could come and do laparoscopic hysterectomy, but when I talk to this patient, the tender caring is more important. Could you hear me?
We are hearing you.
Okay.
Yeah, a request for our colleagues, those who are not muted, please you mute yourself as Professor continue to talk.
And that takes me to talk to you about patient story. For example, Angelia Thornton in 1979, after a series of frustration of impersonal treatment as a patient. This is the lady who was changed in the 90s and talk about plant tree model. And that means the real benefit of plant tree attitude or the philosophy is that if we involve patients in their health care, we will get a better result. Actually, we have to involve patients in their care. We have to tell them we have to counsel them. We have to give them the choice. So, and now plenty of care was something have changed from the 90s and is a good movement that will be a movement in the next century and a term in healthcare. I'm going to share another story. Patrick Barnes. The Barnes family have created DAISY, which is an award to thank all the nurses who looked after him. I'll give you a story about this chap, young chap. DAISY is an award meant for Patrick, which has a disease attacking his immune system. And they established this in the memory of Patrick, who died at the age of 33 from autoimmune. But let me share with you the story of Patrick's. Patrick's have said that she made me laugh. Nurses have talking to him and he had humor. And when I wanted to cry, she exactly know what to do. So that's empathy and compassion. And they listen to his pain, they listen what he wants. And in the same time, they are act on how the patient is feeling. They're attentive. And at the same time, they always explain to him what is going on, what's treatment, what they're going to do, explanation all the time. And at the same time, they are making him actually comfortable, the physical comfort while he's inpatient. And that's is a very important, and all the time he's cheering him up. So that's why the family of Patrick have decided that the compassionate love and care of the nurses have decided to design this award for him. So a patient nomination for this award is now regularly among most healthcare institutions for looking for those nurses and doctors who they really do care. Another story which I would like to share, this is a man whose his wife gave birth, and he noticed that all the staff are well educated, kind in treatment, from nurses to doctor, and this is his experience. I like to know how much they care about all the kindness information. They go through all the details, what they're supposed to be. Very rarely to find a doctor provide that kind of information. And that's the story of this man, that he was looked after by midwife while he's looking after his wife. And he concluded that my experience was different. They share all the kind of information to us, allowing us.
Colleagues, please, can you mute yourself?
Continue, Prof.
Yeah, why do we talk about language of care? I'm just saying that poor communication is the inputs of how many percentage of complaint you think? Anyone give me a guess? It is about 75%. Poor communication is an input for 75% of patient complaint. So very important that we talk our patient in a nice way. This is another communication study which they look into after 100 patients. They send a questionnaire, and that questionnaire, 1% of those have died. They didn't receive it. 3% have moved away from their location. 5% from other friendship. 9% competitive reason. 14% the product of dissatisfaction. But if you notice that 68% had concluded that there is a bad customer service. Patient experience now is very important. It's not how you do a cesarean section or deliver a baby. The way how you talk to the patient, the way how you comfort the patient is very important. That's what we call customer service. So because patients are always anxious, vulnerable, a small act of kindness often make the biggest difference in them. If we talk to them and calm them down, that's very important when you look after them. You always have to look into how you can humanize healthcare. Patient-centered care is very important. I think we all know that the world is in crisis, economy are unwinding, jobs are disappearing, and our speed of being tested. Considering this is imperative for leaders to demonstrate compassion. So we have to be very nice to patients when we see them. Why language of care? As you know that there is 7 habits highly effective to people. The most important one is seek first to understand and then to be understood. So we always listen to the patient, let her talk and understand what is her issue. And then you could be able to understand. So when you listen to a patient, you have to be empathetic, because if you ignore them, that shows that you are not listening. If you're pretending listening and say yes, 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 that's also not. And sometimes we have selective learning or listening. We hear only what's the part of the conversation we want to hear. So my advice or my recommendation is attentive listening, paying attention and focusing energy on the words that are being said is very important. Patients feel appreciated. Patients feel that they are welcome to talk and they will not hide anything. So you have to know that how highly effective the talk of this patient. Always listen empathetically. You have to show the kindness. Effective listening occurs when really you hear the person's story to fully understand their perspective and experience. You have to listen to the patient. You have to give her time to listen to her. This is the biggest study. A large academic medical center showed that when the language of care implemented in the first, and that was in 2010, 2011, and that's among nurses and doctors, you find that the patient appreciation, the customer service increase when they have looked into that study, and then they have implemented the language of caring, and the second time, you can see patient satisfaction is going high up in the scale. Kindness outweighs other consideration. Being kind to the patient, and you can see in this picture how that doctor putting the hand on the arm of this patient. That's saying kindness. In a recent survey by Wakefield Research reported that in March 2014 confirmed 87% of Americans feel that kind treatment by a physician is more important than other key consideration in choosing health care provider. I go to a kind place. I choose the kind doctor. And that's very important. So we have to change the way how we do. Patients pay more, travel further for kindness. 75% of the same Wakefield survey, 75 responded would be willing to pay more to visit healthcare provider who emphasize kindness in their treatment approach, and nearly 88% are willing to travel further to receive kind care. And that's, if you look at it, this is some sort of marketing. Because if patients go outside and talk about this hospital, believe me, that is far important and far and cheaper than paying a hell of money, putting posters, putting everything to advertise about your clinic or about your. This is another area why language care of care. This is based on 6,000 focus group and interviewer, and more than 50 patient family caregiver across the continent. They've been asked, and the top concern of these patients are absence of caring attitude from provider, dismissal and trivialization of patient voice, and lack of continuity of care. This is the most important concern that you find patients blame us or are not happy for us as a doctor or nurses, absent of caring attitude. We are busy, we don't say hello to the patient, we don't look into their eyes, we're always trying to say, oh, no, you're okay. That's not a real complaint. Trivialization, the patient voice, and lack of continuity. They come and see a different doctor or a different nurse all the time, and that's lack of continuity. So I'm just going to tell you that if you satisfy one patient, that reach 5 new patients. But if you disappoint one patient, how many patients will know about that disappointment? 20 potential patients, it will reach them. That doctor or that hospital or that nurse are not right, are not nice. And you can see that the power of if you really care about patient. Yes, you're a fantastic surgeon, but the way how you talk is not the right way. So in another sort of the language of care, you can see that 66% of healthcare choices decisions are based in word of mouth. 96% of unhappy customers do not complain. At the same time, 90% of unhappy customers will not choose your organization next time they need the care. When consumers are dissatisfied with the services, they tell 20 relatives and friends about how not good hospital is that. So when customers are satisfied, they tell only 5. But when they are not, they do that. So employer behavior towards customer is the most powerful marketing and customer satisfaction tool on an organization which is had. So why language of care? You see that I'm repeating the language of care. The language of care is important to lead any healthcare industry. The language of care to empower patients. The language of care, we want our patients to continue to trust us. We want our patients to have positive experience when they come and see us. So let us look to what is compassion. The compassion has a big spectrum of empathy. If you look to this curve, the effort and then the standing of an engagement, a pity is I am sorry for you. Sympathy is I feel for you. Empathy, I feel with you. But compassion, I am moved by you. And that's the spectrum of empathy, from pity, sympathy, empathy, and compassion. So what is compassion of care? How do you define compassion of care? I think the most important thing, compassion of care, is taking action to relieve them, to listen to the patient, to be sympathetic, strong communication. And you have to give the patient the knowledge and consider a person as a whole body. And that's why taking action to relieve them is a very important, that's one of the compassionate care. Can compassionate care be learned or taught? I think yes, I could learn. And that could start from medical school. We could teach our future doctors, nurses, midwives, by giving them some in the curriculum about compassionate, about the way how to talk to the patient, how to engage the patient. And that's very important because at the end of the day, patients come to the place where they feel comfortable, they feel welcome, they feel that somebody talked to them. So if you look to the references, a lot of people, doctors, nurses, clinicians, porter, housekeeper, they all need to be taught how to do that. And that is how education department in every hospital have to lead that. So the time pressure environment, Such a smile of a kind word do not take time. It is 40 seconds of compassion. You see a patient with a smile, standing up, shake hand, put a smile on your face, that take about 40 seconds. And that's what we call compassion. Can 40 seconds of compassion reduce patient anxiety? Yes, it can. And if you look to this, the purpose of this study, they have shown video to stimulate, to assess the physician. And in the same time, they show these 200 patients, some of them are breast cancer and some of them are without breast cancer, show them these videos about the doctor who are talking. And these videos have enhanced the compassion of them, and they're very less anxious when they saw how doctor talk. And these are the video which you could produce in your hospital, showing how doctors care, how nurses care. And if you show that to your patient, you're definitely going to see how people, and in this study or this design, they have noticed that the enhanced compassion signals was short, simple, and effective in decreasing viewer anxiety. Can 40 seconds of compassion reduce patient? Yes, it can. This is an oncologist who counsel a patient. See how the way this oncologist was talking to his patient. I know this is a tough experience you go through, and I want you to know that I am here with you. Some of the things that I'm going to say today might be difficult to understand. So I need you to feel comfortable stopping me if something I say is confusing or does not make sense. We are here together and we are going through this together. And that's the compassion of an oncologist telling patient who had a cancer, the way how they counseled it. At the end of the consultation, the oncologist will say, I know this is a tough time for you, but I want to emphasize again, we are here together and I will be with you in each step along the way. And I think that even this patient had an inoperable or severe cancer, this would make that patient so comfortable that she is not left alone. And that's compassion. What are the benefits of compassion? I think the benefit of compassion is many. One of them, better health outcome. I cheer some patient, greater patient and caregiver satisfaction. And that's actually lower the cost because these are the patients who will come to this hospital because they feel that there is compassion on the air, that everybody in this hospital is kind and caring. So many studies have found that kindness, compassion, and giving care associated with improved happiness, good mental health, a strong immune system, reduce anxiety, stress, depression, improve relationship, and a longer life. When a physician is compassionate, patient heal better and faster, and the doctor are happier and less burned out because you show kindness to this patient. So don't underestimate the benefit of compassion to your patient. Let us talk about empathy. What is empathy? Empathy is the power of understanding and imaginative entering into another person's feeling. You are so deep to know the feeling of other person. Empathy is indication with and understanding another situation, feeling and motivation. Empathy requires emotional intelligence. You're going to ask me, what's emotional intelligence? Emotional intelligence is the ability to comprehend how others feel and react, and to use this knowledge to make sound decisions and avoid unsolved issues. Now, emotional intelligence became a big topic and a big science. There is so many courses to teach health professionals how to have emotional intelligence to support your patient. If we look to the type of empathy, there is cognitive empathy, there is emotional empathy, and there is compassionate empathy. Cognitive is desire to understand. Emotional, desire to feel. And compassionate is desire to help and support. This is a big study about empathy study. This is a study about the relationship between physician empathy and disease complication. It's an empirical study, primary care physician and their diabetic patient. In this study, or the paper published have shown that this is study about the relationship between physician empathy and disease complication. They look into those diabetic patients, if they are treated and with a compassionate and passionate, how do they behave? So when you look to the purpose of the study, to test the hypothesis that the score of validated measure of physician empathy are associated with clinical outcome for the patient with diabetes. And in the same time, the result of that patient of a physician with high empathy score compared with the patient with physician with moderate and low empathy score had a significant lower rate of acute metabolic complication. And that's mainly because doctors are compassionate when saw this diabetic patient. In the same time, the conclusion of that study that these results suggest the physician empathy is significantly associated with the clinical outcome for patients with diabetes mellitus and should be considered as an important component of clinical competence. Not just medication. Patient come, give her the glucophage or give her the insulin. The way how you talk, the way how you listen to the patient, the way how to comfort the patient have a great impact, and this study have proven that. So what is the difference between empathy and compassion? Empathy refers to the ability to sense another emotion and understand their thought. But compassion is caring concern for another distress and suffering coupled with action to alleviate. You could hear here, you hug the patient, this is empathy, but you help that patient in difficulty, that's the compassion. Body language is very important. I just asking you, you could see everybody in this table put a sign of happy. Do you think these people are happy? Body language is very important when we see our patient, when the nurses or the midwife or the doctor see the patient. Definitely, you cannot convince me these are the happy people, although they have put the sign down there. So non-verbal behavior speak louder than words. If you're asking me these are happy, no, they are not happy by looking into their faces. Show caring non-verbally and make your care felt. And smile, shaking hand, hugging the patient. These are the things which is non-verbal. It is not what you say, but how you said it. Mae West have said that. You are never saying nothing, even when you are not talking. Show your caring with your eyes, with your touch, with your tone, with your face, with their space. And that's what counts. I look to the patient, I put a smile in my face, I'm sure the patient will be comfortable to tell you everything. So verbal behavior is very important when you see this patient. How long does it take for a person to form a first impression? If a patient comes to me in the clinic, do you think that how many minute or hour or second this patient will say, oh, Dr. Abubakr is a nice one or is not nice one? The first impression will come in the first 7 seconds when the patient comes to your room. She will feel that, oh, I don't feel that I'm comfortable here. Oh, what a lovely doctor is there. So the first impression is very quick. We judge patient, we judge people very quick. You go to a meeting, you say hello to people, and you can see that, I'm not comfortable there. Let me share with you this video.
Acts of kindness, acts of generosity is how simple it is to make people feel good. I was walking down the streets of New York City, and a guy walking in front of me, his backpack opened and a bunch of paper fell out on the street. I didn't think much of it. I bent down. Acts of kindness, acts of generosity is how simple it is to make people feel good. I was walking down the streets of New York City, and a guy walking in front of me, his backpack opened and a bunch of paper fell out on the street. I didn't think much of it. I bent down, I gathered up the papers, handed them back to him, and pointed out that his bag had opened. Now, in our bodies, there's a chemical called oxytocin. Oxytocin is responsible for all the warm and fuzzies, unicorns and rainbows. It's responsible for all the warm feelings and connectedness we have with each other. Friendship, love. Huge amounts of oxytocin surge through a woman's body as she gives birth. This is what is responsible for the mother-child bond. Oxytocin binds human beings. There are many ways to get oxytocin. One of them is acts of kindness and acts of generosity. It feels good when we do something nice for someone. It feels good when someone does something nice for us. On this particular day, I did something for someone with no expectation of anything in return. I got a little surge of oxytocin. I felt good. He turned to me and he said, "Thank you. It feels nice when someone does something for us with no expectation of anything in return." He felt good. I walked to the end of the street. I'm waiting to cross the street. And a total stranger who happened to be standing next to me said, "I saw what you did back there. That was really cool." As it turns out, witnessing an act of generosity releases oxytocin, and he felt good. And the best part about oxytocin is the more oxytocin we have in our bodies, the more generous we become. It is Mother Nature's way of trying desperately to get us to look after each other. I can guarantee you that that man who witnessed what I did something nice for somebody that day simply because he saw someone do something nice for somebody that day. So what if we commit to do something nice for someone with no expectation of anything in return? Imagine what happens at work. Imagine what happens at home. Imagine what happens with our friends. But it must be genuine.
So I'm going to share with you, imagine that the kindness is the rock, and I want you to take what you need. Rock of trust, magic, peace, faith, smile, joy, love, and that's the kindness. Kindness is all these type of rocks. As we say, every act of kindness is a charity, and that's said by Prophet Muhammad, our Prophet. So that feeling of compassionate care is very important. If you want others to be happy, practice compassion. If you want to be happy, practice compassion. And that's what Dalai Lama has said in his famous quote. I think we all know Hippocrates. We all swear the oath of when we become doctors. I will remember that there is an art to medicine, and that warmth and empathy may be more important than the surgeon knife. So my take-home message today in this lecture is that going beyond the professional boundary can allow us to be compassionate. Empathy is not any more luxury. However, it is an essential ingredient to treat patients. Be more humane. Improve communication will reduce patient distress and anxiety. Talk to the patient, explain to them, listen to them, don't interrupt them. The body language, very important. The patient see you, you're not smiling, you're not looking into our eyes. That is the body language which patient need to have a compassion in this area. Seeing the world the way our people see it allow us to understand how they feel. Reduce suffering. When you combine care and empathy and compassion, it makes for the best overall experience for patient. We cannot control what disease affect people, but we can control the interaction. And remember that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. Maya Anglo. And I end my talk, and if there's any question, I welcome that. And I hope I have add something to your experience, medical experience. And that's where I work. This is Kuwait at Sunset. And thank you very much for listening.
Well, thank you so much, Prof. It was really a very impressive presentations. It's really one of the most important topics in our life as medical practitioners. Initially, we planned that this presentation can be done in person at Juba Teaching Hospital, but due to the ongoing constructions and exam in the hall, then we shifted to our online presentation. It's good enough that the number of participants has reached 56. Now it is time for us to maybe comment or ask any question if we have anything for Prof. Okay, we are welcome. You can raise your hands and okay, we can also put our questions in the chat box. So Dr. Zakaria.
I'm happy to listen if you want to open the mic.
Yeah, thank you. Any question or comment?
Yes, Dr. Jock, can I come in?
Welcome, Dr. Zakaria.
Okay, thank you very much, Dr. Jock, and my appreciation to Professor Abubakr for the wonderful presentation. Sincerely, we are so happy to receive such informative presentation. I'm called Dr. Zakaria Malal. I'm the president of the Association of Gynecology and Obstetricians of South Sudan. Yeah, it's just my references to the topic that has been presented by Professor. I was thinking maybe, yes, if we can try our best as a practitioners to examine our internal practice. How are we dealing with patients and clients when they come to us? Because typically, like what Professor said, when patients come, they do expect a lot from us in terms of dealing them with sympathy and trying to know which challenges are they having so that we can address one. So the comment that I wanted to say is that if within our internal setting, we can conduct some studies which can examine the real situation on the ground, and we see how our doctors, our colleagues dealing with patients. Because right now, if you look into the data that has been presented by Professor, there are somewhere within our continent, yeah. But we need to examine, especially in terms of South Sudan, and from our side of Association of Gynecologists and Obstetricians of South Sudan, we can even join hands with Professor and we do something to see what is the situation on the ground. These are just a comment to Professor, and we shall be happy to coordinate together.
Yes. Yeah, with pleasure. Thank you very much for your wording, and obviously it's a pleasure to be with you. I mean, Sudan is Sudan, and I'm very happy to sort of collaborate with you. As you know now, healthcare have changed a lot, and as I said in the beginning, yes, medicine has advanced, and now artificial intelligence. Now there's your MRI is being seen by a machine. So many things happening. So now there is most hospital or are forming patient experience team, and these are the ones who are. I mean, I'm happy to share with you a questionnaire which you could put it in translated in English, and that could be passed in, for example, outpatient, could be passed in anywhere, and you could use some of the medical student to take this questionnaire and then check with this patient the way how by looking into certain parameters, and that will help you to improve the way how we talk our patient. I mean, when I joined Kuwait, now nearly 7 years, the first things I've done is that I took a group of midwife, nurses, and a few junior doctor, and we went to a conference in Abu Dhabi. This is the first conference, it's an American conference, was about patient experience. And now this is the name of the game in medicine or in healthcare. Patients are center of our care. If they don't have the right care, they will not come again. They will not be happy to come to this clinic or this hospital, and they talk about that. So maybe a small like a study in certain area to, and you could use some of the medical student, and this is a small, what we call audit, and you could see a sample of 30 patients and dig on their the questionnaire parameters, and that will be an idea about, give you an idea about, yes, are we doing the right thing or not? So I'm happy to share with that. I will communicate with Dr. George, so as I could send this questionnaire, and so as we could be translated in English, but as you know that I work with, most of our patients are Arab, but I'm sure some of our nurses, so I'll ask some of the nurses here who are part of the patient experience to translate a survey, and then I send it to you, and you could do a pilot study to know how your patient feel. Is that something you welcome?
Thank you very much, Professor. We appreciate that so much, and we are sure that we can do it together as a team. And we still remember our Arabic. Thank you.
You're welcome.
Yeah, I raise my hand. Can I ask a question to Professor?
Please. Yes.
Yes, you're welcome.
Yeah, this is John Mayer, a medical officer from Wales State Hospital. So I thank the professor for the nice presentation and very precise. I would like the feedback that this will actually improve it, will improve our interaction with the patient. And the question I wanted to ask, I wanted to know whether there are other factors on the side of medical personnel that can affect the interactions, the patient care on the side of the doctors. And whether these studies, whether this parent, patient parent is actually unified, depending on education level and the clinical background and the rest. So are there some differences, the studies that were done like this? Thank you.
Yeah, I mean, patient are patient, whatever level of education they are. You will find a very educated person, but still that person needs compassion and need people talk to him with respect. People show that person that your complaint is genuine. And so I don't think all patients deserve equal right of how we talk to them. Obviously, shortage of doctors nowadays, a lot of doctors are burnt out. They have so many on calls, and they come to a clinic or they come to theater. They are not happy about that. Obviously, that will affect. We are human beings. We are also human beings where we sometimes have our own problem and we come. But the point I want to make that we need, when we come to our practice, when we come to our job, we need to put out all our concern outside and try to do our best to behave in a way that these are the patients who are having problems, who are coming, so as we could comfort them. So, but I agree with you. There's so many challenges affecting us as a human being. I may be sick, I maybe have my child ill. I was on call last night, but the minute I walk in that office, or the minute I walk in that labor ward, I have to forget and do my job. People see us as angel. People look at us as doctor, we come from another world. So we need to keep that image all the time. But at the end of the day, we are human beings. Still patient, they could make a complaint against you because of your behavior, but we do our best. And that's the message I gave you.
May I come in? I raise my hand.
Please.
Yeah, welcome.
Thank you very much. I appreciate the professor, Dr. Abubakr, and the AGOSS team for allowing us to have this nice presentation. Indeed, we have learned a lot. I'm by name Dr. Sobek, a general practitioner in Monvolo County, Western Equatorial State. So mine is inquiry or maybe a question. One of the challenges we are facing in this language of care to our patients while we are delivering our services is the issue of different languages. I may be attending to a patient where I cannot understand English, cannot understand Arabic, only the local language, then I may be in need of a translator. So, and we know when a translator, some of them, they can't deliver the same message, the same information you are giving to the patient, the good language that we have learned today here. So how can we address or how can we overcome this challenge? Thank you very much, Professor.
Yeah, I mean, obviously that's a challenge which any healthcare institution will face. And for example, I remember when I was in UK, we have a list of 120 languages, and we have all our staff from different parts of the world. We're volunteering whenever there's a patient who needs that language, we go. So obviously that's a challenge, a very difficult challenge. And I don't think if your healthcare budget is not that strong to support in that, that's going to be a difficult. And that's part of the struggle of life. I mean, especially I come from Sudan, and I know also when I used to practice down there as a junior doctor, that's an issue. There is people from the north, from the west, from the south. Each one has his language. So it is a difficult. I agree with you. Unless you have a support from your health service in the area, from the Ministry of Health to support that by having people who interpret, is going to be difficult. You cannot overcome that. There is no magical thing to overcome that. And at the end of the day, I think even if you can't talk the language, I think the way how you give a smile to that patient who come inside, and maybe that's something could forgive you that she will have to wait for somebody who can translate. And I don't think I could give you a solution for that. That's here is manpower and it is funding.
Yes.
Yes.
Okay. Thank you.
Yes, please.
Yeah, welcome, Dr.
Can
Wabir.
السلام عليكم. أنا اسمي عبد الرازق عمر روديل. أنا gynecologist, member of the association. First of all, thank you very much, Prof, for the very nice presentation. Although I joined late, but just from the brief presentation that I was part of it, I was able to enjoy the material, and the presentation was good. So mine is just an, in Sudan, we did most of, for those of us who are older, we practice in Sudan. And I remember when there is a terminal illness, for example, we used to counsel the family members, like لو في مثلا زول عنده سرطان، عندنا حسب الثقافة الناس بتقول يا أخي العيان ده قلبه ما بيتحمل عشان to break for him the news of هو عنده مثلا terminal سرطان stage 4 مثلا. And we used to counsel the family members, those who are near to him or to her. How do you look at this kind of approach? Although the right person to be informed or counsel about his condition should be the patient. But now we are using a bridge to counsel a father or a brother, and then for him to deliver the message. So what do you think? Even sometimes the other senior consultant, they used to say, now this guy, since he's terminally ill, it's just a matter of time he's going to die, send him home, let him die in peace, and talk to the family. How do you think on that approach to as a part of patient care, communication, language in the topic that you presented? Thank you very much.
Yeah, thank you for your question. Actually, you have to talk to the family first. Why? Because the family know their parent or their mother. They know who could be. Some patient they will accept to tell them. But I think the only person who could tell you how that person will react is their family. The daughter, the son. So you have to respect the family, because at the end of the day, you're aware that this patient is terminally ill. Obviously, if I'm terminally ill, I have the right to know that I cannot offer any medication for you. And then so you have to be honest with the patient. But obviously, different patients, they react differently. I'll give you an example. When I went from Sudan to UK to study, I have the same concept of you. When I want to break bad news, I go to the family, and then I was shocked that the family have given me the permission, said, no, we would like you to come and talk to our father or our mother and be honest with them. So I think that you have to evaluate the situation depending on how the family reacts. And in my case, they were honest to me. I said, no, yes, we know our father is terminal, but we want you to go and talk to the father. So you have to have that sort of communication rather than just go and deliver the bad news to the person. I mean, there is many courses of how to break bad news. As we were trainee, that's one of the very famous course when we are in training. And I would recommend that you should have a course like this in where you work. Maybe in the future, when you run any sort of conferences and you want to do workshop, I would advise you, breaking bad news is a very important. And we used to give it to the medical student. We used to give it to doctors in training. And then in the induction of every time there is new staff coming to the hospital. So maybe one day, I have just saw that you have a conference in Juba in November. That may tempt me to come and join you down there. Thank you.
Yeah, thank you so much, Prof. We have two hands up, Oyela, Josephine, and Maureen. Maybe you can ask if you have any comment before we wind up.
Please.
Maureen Okango.
Thank you. Thank you so much for your time, Prof.
Pleasure.
Let me go to a quiet place, sorry. So my name is Maureen Okango. I'm a gynecologist and a fistula surgeon from Kenya. And
Wow.
I really learned from this talk. My question would be, okay, and I'm actually challenging myself to go and do an exit survey on our clients. I work in a public facility. So I just want to, I'll probably sit and find, if we could have maybe a sample of a questionnaire, it would really help, but I intend to do that. My question is on these clients who maybe end up with bad outcomes in like a mothers who lose their babies and they end up with IUFDs. And sometimes when we're doing a ward round, I find it's not in adequate time to really address their issues. And sometimes they're still emotional. They'll not ask many questions. So I have this habit of taking their phone numbers to follow them up later once the dust has settled, to just maybe call them in to a clinic, talk to them. But I'm wondering, is there something more we can do for them?
Yeah, I don't know if you have in your department counselor, psychologists, people who have bereavement officer. We tend to have that. I mean, in my previous post in UK, every unit or obstetrical unit have a bereaving officer and have a counselor and have a psychologist, where when we want to bring bad news for a pregnant patient who lost her baby, that's the meeting we do. We don't go as an obstetrician alone to talk to her. You need to have, this is a very sort of a traumatizing event. So you need to have a support when you go and break that. And even if you don't have that setup, I think you need to sort of spend some time with one of your midwife, so as she could have certain courses. Nowadays, there is so many courses of how to break a bad news, prevent things. I think you need to support that rather than you to go and talk to her over the phone. No, this patient need to have face-to-face talk. I don't think so. It's not in the ward, but I'm sure in your ward, there will be a room where you could have that, and you always have somebody with you in that. And midwives are fantastic in comforting patient. So that's what's all my training. I was supported by this type of colleagues who are very important in the services of breaking bad news. And one of the courses which I would like you to think about it, even online, how to break bad news. There is an art of breaking that. There's an art of how to prepare your patient for the bad news, and who will talk and who will support. So that's my sort of advice to you.
Thank you, Prof. Thank you so much.
You're welcome.
Okay, thank you. Oyela Josephine, if you already have seen your hand, then Dr. Grang Dagjor will come after.
Yeah.
Yes, there's a hand up in the name of Oyela Josephine. If not, Dr. Grang can come in.
Thank you, Dr. Jock.
Yeah.
I would like to thank Professor Abubakr for this nice presentation. It's really informative. And I would like also to thank Dr. Kango from Kenya. It's really showing solidarity that the East African community is joining together for learning. And it's a privilege to us in the Association of Gynecologists and Obstetricians of South Sudan to have colleagues from Kenya, Uganda, and most of the East African countries. Mine is not a question. It's just an interaction with the presentation and the challenges that we are facing in the country. With our fragile system in the health in South Sudan, it's not always straightforward to convince the families, the patients that are terminal to just take the patient home and just let her die in peace, as Dr. Abdurazik was talking about, because they sometimes believe that the diagnosis is not correct, so we better go to a different place outside the country for treatment. I do have an example of my relative who was sick almost like 6 or 7 years back, and he was diagnosed to have hepatocellular carcinoma, the end-stage disease. And I tried to talk to the family that this patient is not going to survive. And it was really a problem to me in the family. Most of them were annoyed that how can I talk like that? And they finally decided as a family to take the patient to Sudan. And unfortunately, the patient was taken and the patient died on landing to Khartoum International Airport. So instead of being taken to the hospital, so the patient was taken to the mortuary, and the preparations were done again to bring our relative back. That is one example. And the other example is whenever you tell them here in this country that the patient is almost any stage, they will still ask you, sometimes even they might label you that you are not a good doctor. They will just tell you that how can you talk to the people like that? And despite knowing that this patient is almost terminal, one of the patients was at least a month back to my own clinic. It was advanced cervical cancer, stage 4 almost. And I tried my level best to talk to the family, and the family was they were courageous enough to tell me that you talk to the patient and try to talk to her. But when I talked to her, the mom was telling me that I'm not yet convinced, and I have to go for further treatment abroad to at least now get convinced. So it was up to the family now. Unfortunately, she was taken to Uganda, and she died on the road to Uganda. So these are good examples that we are having here in the country. They are not so good because they are really traumatizing, but these are the realities that we are having in the country. And I think with this presentation, it will add on our efforts to do more, at least to try to reduce cost of traveling, to try to reduce the cost of traveling and other implications that are associated with this. So thank you very much, Prof. This is an informative presentation. And we in the Association of Gynecologists and Obstetricians, we are ready to work with you to do a survey, in-country survey at least, to have our own data in the country, because it's really a stressing issue in the country with the fragile health system that we are having. We are spending a lot on referrals for cases that are not actually meant to be referred, because they are terminal cases. Some of them are dying before even they reach. Some of them are dying when they actually reach. So thank you very much for this presentation.
Yeah, it's a pleasure. It's a pleasure. And if any help I could do, yes, I will share survey papers so as you could do a small study or an audit to see how patient will value your services in a clinic, in a theater, in the ward. More than happy to be part of your group, and hopefully one day I'll join you that in one of your East African meeting. I think now you have a very powerful East Uganda, Kenya, Tanzania, and actually I'm now I became a frequent flyer to Zanzibar. Now I think one of the medical colleges in Sudan now moved to Zanzibar. Professor Qureshi, he has a medical student down there, so I tend to go and support them voluntarily to help, and that's what I'm happy to be of help for all my fellow African. I'm still an African, and Africa is the future for Africa is very important for all of us. So we have to do something for the motherland by those people who went to diaspora and they learn. It's a time to come back and try to help even in education for our medical student, for our colleague, for now we are sort of trying to collect a group of people to go to Port Sudan and try to help people down there, because medical services is now nearly zero. So unfortunately, but it's been a pleasure, and thank you very much for the invite. And please, I'm more than happy to share my email already with Dr. Jok with you, and I'm happy to for any advices. I'm happy to be of service. And thank you very much for inviting me.
Thank you so much, Prof. Thanks everyone who participated in this presentation, this very important presentations. And okay, welcome, Dr. Zakaria.
Just I wanted to read some comment within the chat box so that Professor can appreciate those ones. Yeah, from Dr. Simon Tabia. Simon says, this is one of the best presentation. I have learned a lot. Thank you, Professor. Also from Dr. Zainab, she said, thank you, Professor, for the wonderful and brilliant presentation. Thank you a lot. Thank you and be blessed. From Dr.
Thank
Lee,
you very much.
she said, this has been a very wonderful and educational sessions and express the importance of strengthened health professional soft skills. Also from Dr. Short Dagarang earlier from Tanzania, he said, thank you so much for the great talk, Professor. Also from Dr. Bullis, he said, thank you for a very nice presentation, Professor. It's well appreciated. From Dr. Lijo, he said, powerful presentation. Thank you, Professor. And as it continues, we have from Dr. Victoria. She said, thank you a lot, Professor. It was really a good presentation. The way you deliver information, engage us in the topics so well and really add something to us. And this will improve my personal interactions and delivery of information to the patients. From Rebecca said, thank you for these important topics. And also from John Sobek, he said, thank you, Professor. From Juma Edijo, he said, thank you for the wonderful presentation, Professor. And also to AGOSS for organizing such webinar. From Dr. Isa Richard, Dr. Isa said, this is wonderful presentation. Thank you, Professor. And he also appreciates AGOSS. Dr. Isa is a urologist from Tanzania. And also we have Dr. Amum from Wadakona. He also appreciates the presentation. And also we have Dr. Voni, who said thank you, and he also appreciated the presentations. I think these are some comments within the chat box. And from our side, Professor, we also appreciate you so much as an association of obstetricians and gynecologists. And it will be our pleasure if you would come to our conference, which will be in November from 16 to 17.
Yeah,
appreciate you so much.
Thank you very much for the invitation, and thank you for everybody who attended. And I'm here to be your services if you needed anything. You have my emails, and we'll take it. And I'll do my best to come. Actually, I was talking to my friend, Dr. Hani. I think some of you know him, and we decided. But the problem that now people in Rwanda, Kigali, they are also doing some conference around that time. So we'll see what how things will be. And again, I definitely would love to come to South Sudan. Thank you very much.
Thank you.
Okay. Thank you very much, Prof. Thanks everyone who attended this presentation, our colleague from Kenya, Tanzania, Ethiopia. Thank you so much. Thank you so much, other members and members of AGOSS who show up this evening to attend this presentation. The attendance was overwhelming. We are so delighted about that. We will again announce our next CME that will be by the end of the coming month. Okay, you can get it on our Facebook groups where we used to share things. Also, we have our Telegram group that I shared just in the chat box so that you can join for presentations, because we used to share all the material that are presented there. We will get this presentation from Prof, and all of you will get it in the Telegram group. Prof, thank you so much. This is just our first presentation. We will learn a lot from you. I know there are so many things to learn from you. We are also happy that Dr. Hani is back to his health. He recovered after he was down for some time. I'm happy about that. He was asking me about this the pre-conference CME. He was asking that question, and we will be happy if we can have the two of you in addition to Dr. Sami Mahmoud. That will be a very
Yeah, Sami
great
is
pleasure
the
for us to have you guys. Yeah.
Is he the AFICO president now or not?
Yes. Yeah.
Yeah.
Yeah. So
hopefully-
we will be happy.
Hopefully that will be your program. Are you having workshop or just
we are putting the plans, and then I will communicate that with you, with Dr. Sami, and also with Dr. Anisha Anifauzi. We will communicate that.
Okay.
Thank you so
Thank
much.
you.
Thank you. Have a good evening. Thanks,
good night.
everyone.
Thank you. Bye.
Good night. Bye, everyone.